I'd like to welcome everybody. This is the Musella Foundation's Brain Tumor webinar series for Brain Tumor Awareness Month. We have one of these every Sunday in the month of May. Our first guest is Dr. Stephen Brem, Professor and Chief Neurosurgical Oncology from the University of Pennsylvania, speaking on innovations in glioblastoma therapies. Go ahead, Dr. Brem.
Thank you very much, Almacella. This is a view from my window from Tuesday, and you can see here the Thunderbirds and the Blue Angels over here as they did a flyover Philadelphia. And I just want to tell everyone I realize that in addition to brain tumor, the COVID-19 has really brought a lot of things to a halt. And we are very empathetic. And I have to also say that Al Masella is one of my great heroes. And now everyone is in the virtual world. But for the last 10 or 20 years, he was way ahead of his time with virtual trials, virtual education. And so I'm going to give you a walk through our Penn Brain Tumor Center and some of the projects that are ongoing. These involve many teams, and over the last 3 years, I've been involved in about 35 publications, and I won't go through each one of them, but we're very excited. We really feel like we're on the 1 yard line, making a lot of progress with glioblastoma, and as soon as we get back in gear, I think you're going to hear more from Penn. So Sidney Brenner, who won the Nobel Prize, said that progress in science depends on new technologies, new discoveries, and new ideas, probably in that order. And every once in a while, there's some major advance, such as CAR T-cell or informatics with brain imaging, that results in new discoveries and new paradigm shifts. And so one of the major changes, and I'm biased as a surgeon, but the journey of a patient with a brain tumor always starts first in the operating room, and brain mapping techniques have come a very long way, and you'll hear more about Connectomics. We also have better clinical trials and targets with the genomic revolution and better collaboration. There are more dream teams. We have set up a translational center of excellence that is now led by Donna Rourke, but brings together 20 scientists, many disciplines. And so it's rather extraordinary, the amount of innovation that's going on at Penn currently. And this was an editorial I wrote this year, but this is called the Gardner Cycle, and it goes through new technologies once they trigger a new area, a new field. There's tremendous inflated expectations. This might even be analogous to the hydroxychloroquine if we think of COVID-19. And then we get into a trough of disillusion. And then we start to see a slope of enlightenment. We start to see where there are applications and where this fits into clinical practice. And I think what we're seeing was there have been so many innovations in the last few years that we're coming to the final answer for glioblastoma will be a combinatorial combining immunotherapy, anti-angiogenic therapy, electrical field therapy, and more effective surgery. So it's always a combination because this disease has multiple targets. It is called multiforme for a reason. So one of the things we put together a book a couple of years ago on glioblastoma, and Jill Barnhold Sloan contributed this chapter on the epidemiology, and it's been noticed that there's increase in survival. There's been a slow increase every year, but now suddenly a big inflection point. And what is causing that? Is it the immune system? Is it better surgery? Is it this occurred before temozolomide was introduced in 2005? So is it all of the above? Is it the social determinants of cancer therapy, better support groups, better education, things like the Masella Foundation? It is curious and it's important. And as a surgeon, here's a case that this is one example what we'd like glioblastoma to become, a cyst that we could just go in there and remove, separate it from blood vessels, and not invade the brain. So this is a patient had a good outcome, just compressing the brainstem, which you would think is in a bad area, but because it has a very discrete border and is clearly delineated, that's fairly easy. Now with glioblastoma, we know this disease that invades the brain. And so over the last few years, we've developed diffusion tractography, which allows us to see what's invisible, which are the key highways in the brain. These are the white matter tracks. And so anyone can take out any tumor, but it's keeping the patient intact, keeping a patient whole. So this is a thalamic tumor, but here we can see the motor fibers are pushed forward. And so this will guide and inform the surgical approach. So it will come in a more posterior manner to avoid paralysis. This patient did quite well, and the tumor was completely removed. The same here is in the left temporooccipital area, risking speech, which is mediated by these fibers, the IFA fibers, and we have a functional MRI and also vision back here at the optic radiations. But by coming in, taking this approach, we can avoid those critical fibers. So this is increased safety and allowed neurosurgeons to be more aggressive, and I'll show you in a minute why that's important. So even though we have these probabilistic maps of the brain and we can computerize assessments of these tracks, we still individualize each patient. So this is an example of personalized medicine. We published this with Dr. Verma, who has been a real pioneer in diffusion tractography in our Department of Radiology. And so this is, we do a simulation preoperatively, and then we do stimulation of these fiber tracks with brain mapping, looking at the white matter tracks intraoperatively. This is the tumor, and it's just like that cyst, it's displacing the tracks. And we create a virtual zone, a safety zone. And so we plan our operation and all our maneuvers to be within this zone and not to damage the tracks. And at the Society of Neuro-Oncology this year, I've been privileged to organize a symposium with Michael Shagru, with Mitch Berger, with some of the leading experts in diffusion tractography, Dr. Golby from Harvard, and so on and so forth, on Connectomics. And this is based on the Human Connectome Project, which was by Matthew Glasser. And this was really a pioneering and breakthrough work in which the brain is divided into perhaps 180 areas. 97 new areas were identified. This is like the Human Genome Project. This was the Human Connectome Project. And we are adapting this now through Connectomics to a new generation of brain mapping. One of the problems in brain mapping has been edema, that the virtual tracks, these are not real tracks like cranial nerves that the surgeon can see, but the virtual tracks are obliterated by edema produced by the tumor. And again, Dr. Verma in our Brain Tumor Center has developed a mathematical algorithm to correct for this artifact. So this has resulted in highly sensitive, specific, clinically relevant tractography. And this is from a recent paper that we published with Dr. Verma, Fraser Henderson, our fellow. And so this is here a tractography with a tumor and edema, and you really can't see the fibers, although they exist. So this is with conventional tractography. This is with more advanced tractography. You can see the corticospinal tract in blue. But if you start to use a Hardy technique or multi-shell techniques or with probabilistic techniques, and you do cortical mapping in the operating room, you begin to see the full picture of where function is, such as motor activity. And this has helped a great deal using all of these modalities. And this is what we're using, the most advanced informatics and artificial intelligence to look at the brain, not only just as speech is over here or motor is over here, but we now realize that the brain is organized in networks. And we look at a tumor, it isn't just a deposit of tumor cells like it is in the liver or bone or lung. It's in the brain. And so what we, as patients are living longer, we want best outcomes, and the best outcomes will be with the sophisticated knowledge of this wiring through the connectomics. Now, there's plenty of literature saying that the more you remove, and 80% seems to be a critical threshold value. If you can get 80% of the tumor, that translates into prolonged life. And here's some work from Dr. Sawaya's group. If we can remove more than 100%, if we can remove some of that infiltrative edema where those pesky cells persist, that also translates into increased survival. So we know that cytoreductive or an aggressive operation is a prerequisite to all the other therapies, such as chemotherapy, radiation therapy, immunotherapy, anti-angiogenic therapy, electrical field therapy, for both theoretical and practical and observed reasons. These other therapies work better when there's minimal residual disease. And so we're beginning to see long-term survival with more extensive, we're beginning to see in many of the trials, 25 to 30% of patients are living much longer than formerly. And is that better surgery? That may be part of it. Is it immunotherapy? And so that's an exciting development in the field. And Supertotal resection is the most important parameter now, more than age of the patient, performance status, or tumor volume. And this is some of that data. And what we also know now is that if we can do an unblocked resection, that leads to a better outcome rather than a piecemeal. Very large tumor, it's hard to just take it all out like a cyst, but if we can stay on the border of the tumor and remove it, that will be a little bit more gentle and lead to better outcomes. So this is a compilation in Nature of many studies showing that the more one removes here, this is from Nader Sinai, and 80% seems to be a magic number, 78% as a critical threshold for how much tumor one can remove, and that translates to better survival. The reason for that is that there are practically 100 billion cells in a lethal tumor, but you begin to get symptoms at 10 billion. So here's the math. And if we do the surgery and we get 99%, then there's much fewer cells for radiation therapy and then chemotherapy. And here you could turn brain cancer into a manageable chronic disease. But because of these residual cells that disperse throughout the brain, there's a return, and that's when you get the second round of radiation therapy or the second stage surgery and more rounds of chemotherapy. So this is looking at it from the cellular level. This is something we were going to present at the AANS, but because of COVID-19, it became a virtual meeting. This is from our poster. We have this concept of oncofunctional balance, which was first introduced by Hugh Dufault. And it's becoming apparent from many centers that one technology alone, such as brain mapping or weight craniotomy, is probably not sufficient to lead on the path of optimal results. But if one can combine that, so here we combine navigation, integrate into the operating microscope, diffusion tractography, electrical stimulation, and fluorescence. At our institution, John Lee has done a lot of work, really pioneering work with ICG, which I've begun to use in my practice, and it does make the tumor glow, but it also allows us to define borders, to go precisely exactly where the tumor is, and overall leads to a better outcome. And actually, Skip Grossman with NABIT began to realize that survival of patients now, after many years of really frustration and not increasing survival, all of a sudden everything that we tested, telampanil, selengitide, poly-ICLC, all in in phase 2 trials, all of them were doing much better than the historical trials. And so I think it's probably not that all of a sudden we had 3 home runs and all those other years we didn't have success. What's happening is there's something apart from just these novel agents. And while I have the broad audience, when I first meet with a patient, discuss surgery, I talk about clinical trials. I so much believe in clinical trials because there's data from SVROM and others that being in a clinical trial is very, very important because the outcomes are better, even if the agent ultimately proves not to be that effective. Just the intensity of medical care. I don't think it's the placebo effect. I think it's the intensity of medical care, but it may be some other factor, maybe psychoneuroimmunology. We don't know. But patients do better being on clinical trials. So by all means, go to a center where you get treated. Treated first is important. It's absolutely important to have not only very advanced surgery, but also clinical trial infrastructure. We have that at Penn, led by Dr. Arthi Desai, Steve Bagley, Eileen Maloney, and many others. So I wanted to say that the 5-year survival now for brain cancer, all forms of brain cancer, is going up, so that it's possible to think of that historically in cancer was cure 5 years, and was unthinkable that brain cancer would be cured. But now we see when we especially combine metastases, patients who have metastatic melanoma to the brain, like President Jimmy Carter, come to the hospital quite concerned, leave the hospital with immunotherapy, with a big smile on his face, and no evidence of disease in the brain. So we're making huge progress. We still are not there where prostate, testicular, and breast cancer are, but we are definitely turning the corner in brain cancer. So some of the clinical trials that we have ongoing that were just temporarily suspended with the COVID-19, the reasons for that are apparent. First of all, the whole hospital has changed resources so that we're a COVID-19 hospital, and research in general has been put on hold. We don't want to expose patients who come to the hospital for an experimental therapy because there is an extra risk. In addition, we don't want to muddy the water with the science because if a patient is going to get the virus, how is that going to affect the outcome? Is that going to spark an immune response? Is it going to destroy immune response? And our patients with brain cancer obviously already are immunocompromised. Many of them have low lymphocyte counts. Many of them have immunosuppressive molecules like TGF-beta or IL-6. So these were some active trials that we had ongoing before the COVID-19 crisis. One is ABTC1603, in which I take out the tumor and inject an adenovirus, and then that's paired with an immune checkpoint inhibitor that came from Nina Chioka's group in Harvard, but was throughout the consortium. We also were the largest accruers for Inovio, which is an electroporation. It's a DNA vaccine looking at TERT promoter and 2 other antigens. The preliminary data will be presented at ASCO this year, and it's very promising. I did that work with Steve Bagley and Arthi Desai, and also Don O'Rourke in his laboratory. And so that looks very promising. Inovio, by the way, is one of the leaders now in the anti-COVID the search for a vaccine. We also work with a company called Medicena, which targeted IL-4 through convection-enhanced delivery, and they also got very promising preliminary data in a phase 2 trial that was with Dr. Sampson and Mike Vogelbaum's now at Moffitt Cancer Center. So it was a multi-center trial, and we looked at an antibody to IL-4. IL-4 is one of the molecules that is immunosuppressive. We also look at ABTC1601, which is a Phase 0 has a component which is called window of opportunity. You may hear more about this. The Ivy Foundation has given the largest grant in history of brain cancer research to the Barrow, $50 million, to just look at that one question of whether drugs actually get to the brain. So surgeons are able to harvest tissue at time of surgery and then see whether the drug, which has been given a few days before surgery, actually gets to the brain. Because as we know, blood-brain barrier has always been a big problem. This is a really exciting trial, TOCA 511. The results will be coming out in, I believe, in JAMA Oncology very soon. Unfortunately, it may not be as exciting an outcome as we had hoped for, but the science here was impeccable in that one injects a virus, then gives a prodrug, a cysteine deaminase, that then turns into an anti-cancer drug, then kills the, so this is an antifungal drug, and now turns into 5-FU through the cysteine deaminase gene. So it's a gene therapy, it's a surgical therapy, a viral therapy, an immunotherapy, and a chemotherapy. In preliminary trials and preclinical work, significant survival advantage. Some of the major randomized trials have been disappointing, and that may be because the standard of care is so, patients are doing better in general. But I think those results will be out soon. And this is the preclinical studies showing the tumor disappearing with TOCA. We know that metastatic melanoma to the brain now can be treated in the clinic with any one of the immune checkpoint inhibitors, pembrolizumab or Nivo, and the Nobel Prize in 2018 was given to the discoverers of immune checkpoint inhibitors. We'll be looking at trials, looking at PD-1. PD-1 has been disappointing for glioblastoma because it tends to be a cold tumor, less neoantigens, and also in a very immunosuppressive environment, lots of cytokines that inhibit some of the killer T cells. So there's a big effort in terms of translational research to turn the glioblastoma from a cold tumor to a hot one. Now this, Almasol wanted me to be sure to mention the T cell, CAR T cell. As you know, Carl June has received FDA approval for many incurable lymphomas and leukemias through work over the last 10, 15 years. And a couple of years ago, this landmark paper was published by Donna Rohr and our team with Carl June's team, showing that CAR T cells single dose could have profound biological effects, including inducing adaptive resistance in recurrent glioblastoma and antigen loss. The EGFR-V3, which was the target, which is seen in about 30% of glioblastoma patients, was knocked out by the T cells. There was T cell trafficking. And what's most exciting is that the T cell, the clones proliferate in the systemic circulation and persist. And it has very non-toxic therapy. So there's T cell trafficking into the tumor, despite the blood-brain barrier and all the other concepts of being a cold tumor. There's clonal proliferation of these cells. So this is like a drug that keeps on giving a sustained response. And one patient that we'll be reporting with Dr. Rourke is a long-term survivor over 3 years and then died of some infection not directly related to the vaccine. So the barriers to success have been this immunosuppressive environment. Their PD-1 inhibitors, their Michael Lim, many others are working on developing PD-1 inhibitors. We're looking at other targets as well. There's the heterogeneity of glioblastoma. So the next generation of CAR T may have multiple warheads, may look at more than one target, and there are many candidate targets such as IL-13 alpha, et cetera. In fact, this work from City of Hope also was published in New England Journal of Medicine. Rarely publishes a single case report, but it was very promising and exciting in that IL-13 was a target. This came after Donna Work's paper, but it showed regression of a multifocal glioblastoma that previously would have been considered hopeless with spinal metastases. And what they did at City of Hope was actually deliver the CAR T cells through intraventricular delivery and through a Meyer reservoir. And they looked and analyzed the CSF, and they saw a disappearance of these multiple tumors. And they could also see a bit of an elevation of these cytokines, the interleukin 10, 8, interleukin 6, which we consider an exciting target, the IL-1 alpha. All of these are nonspecific inflammatory cytokines, but show evidence of activity. And in fact, when CAR T cell is effective, like in leukemias and lymphomas, there's often what's called the cytokine storm. And the treatment for that is FDA-approved drug called tocilizumab. And we are now very interested in working with Steve Bagley, looking at anti-IL-6 here as a target for glioblastoma. So let's talk a little bit about IL-6. This is a project of mine that it began at Moffitt Cancer Center. They were interested in why elderly patients seem to get very bad cancers throughout, whether it's colon, breast, or brain. And if you want to avoid getting cancer, just avoid getting old. So this was from, this is well known. It is also known at the cellular level that as one gets older, there's what's called immunosenescence. The immune system is less effective, but also there's a localized inflammation. Inflammation is the root of so many diseases: stroke, Alzheimer's, arthritis as one gets older. So, and the cytokines work on the macrophage. They also affect the T cells and the killer cells. They're also involved in angiogenesis. And so Judith Campisi came up with a hypothesis that if you looked at these cytokines like IL-6, IL-8, and so on, they can activate the p53 mutation and release the brakes for cancer formation in older patients. So we studied that, and we found, in fact, that IL-6 was elevated in, here it is, in patients who lived longer, was correlated with age, prognosis, had a worse prognosis, and progression from low grade to high grade. So we're very excited about that, and commercially, Roche makes an anti-IL-6. And after a mouse model and after a presentation with Dr. Steve Bagley and Dr. Arthi Desai, they finally have released this and will be studied through initially the NCI through the ABTC, but that clinical trial has been approved and now will be done through NRG, hopefully. So we know that this mouse model was done at Penn with Yi Fan's lab. There's a colleague of ours, and he found that IL-6 is produced by endothelial cells in glioblastoma, and it leads to M2 polarization, which means a heightened immunosuppressive state. But in knockouts of IL-6, you get an immunostimulatory state. In effect, you're making a cold tumor into a hot tumor, exactly what we want. So this is all of this scientific data. It's then been extended and confirmed in a study from Northwestern that talks about the myeloid suppressor cells, the systemic effect on the immune system. So the cells don't necessarily need to, the IL-6 does not necessarily need to cross the blood-brain barrier, but can activate the immune system. And this was in the animal model, there was much better, the survival curve moved over, and we're hopeful that in a few years we can present this to you, Al, as increasing survival in humans. It's always been a problem since many things, as Judith Folkman would say, can cure mice, but that translation piece has always been tricky because of the heterogeneity and the immune status, blood-brain barrier, and the size and the of the brain tumors. But in the animals, the control tumor lit up, and the IL-6 that had a knockout, there were the tiny tumors as measured by bioluminescence. And we could see that at the histological level. So some of the other studies that we've done at Penn, we were part of the trial with Roger Stupp with electrical fields, and I'm sure the audience is familiar with that. Steve Bagley and Arthi Desai are now going to take that a step further and looking at PARP inhibitors, and they have a trial with Novocure looking at TTF with PARP inhibitors. So I just wanted to leave a lot of time for questions. I wanted to put in a plug that we have an annual Brain Tumor Center CME course. It's usually in the spring, but because of COVID-19, it's been bumped to the fall. We don't know whether that'll be virtual, online, or a real meeting, but you can mark the date, October 30th, and we're preparing to make that online. The Society of Neuro-Oncology is still going ahead with an actual meeting in Austin, Texas on November 18th, and we'll have a whole day symposium on brain mapping, FiveAla, Connectomics. I'm doing that with Kostas Hadjipanayas, who's a major leader in FiveAla and visualization, and was responsible for getting FDA approval for FiveAla. And we'll have our own John Lee there, and just many of the superstars in brain mapping and in visualization in Austin, Texas. We've also started a second opinion program. If you have any questions or cases, you can send it to me directly at this email, stephen.brem@penmedicine, UPenn.edu, or even stephenbrem@gmail.com. We have a nurse navigator who's just terrific, eleanor.miller2@penmedicine, UPenn.edu. Here is her phone number. So I'm sure there's more questions. What we want to do is make invisible the brain's black box into something visible. So thank you for allowing me to broadcast from the city of brotherly and sisterly love.
Thank you so much. That was very interesting. We have a whole bunch of questions. The first one is, you mentioned the 5-year survival for brain tumors. Do you know what the number is for glioblastoma alone? The 5-year survival rate?
I'm sorry, what is the question?
Oh, I'm sorry. You had a graph that showed the 5-year survival rate for all brain tumors.
Oh.
Do you have one for just GBM?
Well, we're seeing it in the polio study and the Deceive Acts study of Linda Lau and the Lomestine study, many studies, that there's a significant tail. So it's quite binary. There are a significant percentage of long-term survivors. So I hate to give a round number because it's such a bell-shaped curve. So I try to stay away from that, especially in an audience of this sort.
Okay. It's funny that you mentioned DC Vax. We had a bunch of questions about DC Vax. Do you have any idea when the final results are going to be presented? About?
Yeah.
Because they keep telling us like in 2 or 3 months, but they said that like for the last year.
That's a good question. I'm lucky to be on the steering committee, but I don't know exactly. I know that.
Don't say anything that you're not allowed to say.
Yeah. No, I know that they're working really with they're working on that, and it is imminent. And but I haven't seen the final results. As you know, it's a tricky trial statistically because of the crossover rates.
Right. That was actually the next question. They were saying, is it even possible to get FDA approval when the trial was designed in that way, where you do have the crossover?
I think it's a great question. 90% of the patients on the trial, as you know, received either upfront or on the crossover. So teasing that out as it's not a classical randomized control trial, that's for sure.
Right.
But we did publish in Journal of Translational Research that there was a significant number of long-term survivors. So
good. Okay.
They're looking at radiological markers. We do need a better biomarker that would really enable all of these trials to be more meaningful and be able to stop ineffective trials and be able to accelerate effect when we see an effect.
Okay. You showed a couple pictures of these white fiber tracks.
Yes.
The question is, when you have a tumor, does it push those tracks away or does it grow into the tracks?
It's both. It displaces and interrupts. There's Pat Kelly years ago looked at the spatial distribution of gliomas, and the ones again we as surgeons like are the ones that displace, not replace brain. But the gliomatosis or the post-avastin or just some tumors just start out being very infiltrative, and those are intermingled with the white matter with the axons. And yeah, Dr. Michelle Monge from Stanford has some really nice work on how tumors grow through the tracks.
Okay. There was a question. You mentioned glialin, well, 5ALA. If somebody had a choice of going to a center that had using either glialin or intra-op MRI or intra-op ultrasound or a mix of those, which ones would be preferable?
Yeah,
Or could you use all three at the same time?
yeah. I Yeah, that's interesting. So I wrote a commentary in neurosurgery where one group in Milan had developed contrast enhanced ultrasound
Hmm.
with 5ALA. I think more than one technology is probably better than one alone, but we're using we use four. So we use the navigation and the
Okay.
tractography and the glowing tumors. Um, and brain mapping. I, I don't know that there's a magic number or a magic combination. I think what you want is a center that has a lot of experience using these tools and really is looking at that goal of getting at least 80% out. So
Okay.
it's some of these technologies have a little bit of a learning curve. So I think
Yeah.
in the hands of an expert.
There's an interesting question I've never seen before. Why do you not, at the time of surgery, inject even a chemotherapy or just inject some things that you know don't really cross the blood-brain barrier too well, and just take that opportunity to use some drug instead of just do a surgery?
Yeah, well, as a surgeon, we like to not only take bad stuff out, but put good stuff in. And that's why the viral oncolytics are appealing. My brother Henry Brem pioneered the gliadel,
Yes.
which is now enjoying resurgence, perhaps with immunotherapy. So there's going to be some trials there. And we do use gliadel occasionally.
Good.
So,
Um, did you ever use gamma tiles that just got approved by the FDA recently? It's similar to Gliadel, but it's radiation instead of drug.
yeah, it's very interesting. I was part of a study using the Glia site, which was a local delivery of
I remember.
radiation, and it's like brachytherapy. The uh, the first results of that are good and promising. The problem we didn't adapt it attend is because there's such a strong commitment for clinical trials and the effects of that, it's going to have side effects of necrosis. It may have some effect on the immune system, good or bad. It's a huge variable. So I don't know that I have an open mind to that.
Okay. You use the term neoantigen. Could you just explain what that is?
Right. So tumor cells on the surface have um, have antigens, but they don't have enough antigens really to stimulate um, the immune response. But when a cell dies, proteins in the cell membrane break down, and these are called new antigens or neoantigens. And these then become recognized as in tumor cell as a foreign antigen and can excite the immune response just the same way that a virus would. Um, and so that is picked up by the dendritic cells that then program the killer T cells, the CD3, CD8 cells, and then stimulate a directed attack on the tumor. So neoantigens are good in terms of converting that immunologically cold tumor to a hot tumor.
Okay. Um, you mentioned a couple viral therapies. Is there any fear now that working with viruses because of the COVID-19 pandemic, uh, there's some fear that maybe we could trigger a new type of epidemic? Would that maybe slow down the development of these therapies?
It is paradoxical that they're like anything else. There are good viruses and bad viruses, and the COVID-19 is a real bad virus. Um, the ones that have been used at MD Anderson, at Mayo Clinic, at Duke, at our place, at Harvard, um, are attenuated viruses, so they don't have that. Uh, they don't spread throughout the brain. They don't cause strokes. They don't have the side effects. They're not transmitted through the like flu. So they're very different viruses. Um, is there any fear? They are treated as a biological hazard material. We do take precautions in the operating room, um, but so far nobody has had a severe bad side effect as far as I know.
Okay. For somebody with a glioblastoma, after surgery, radiation, and tumor, they have a recurrence. When would you decide to do a repeat surgery? At what point? What would trigger you to say it's time to do a repeat surgery?
Well, yeah. So we make those decisions as a group, and we show the films at a tumor board. And so the first thing is this really a progression or a pseudo progression? And we have lots of literature on that, lots of tools that help us guide that decision. Um, so that's one question. Particularly if the patient had a MGMT methylated GBM and was on temozolomide, and we might get a perfusion MRI, might see if that's cold or hot in terms of blood flow, blood volume. That might guide our decision. We don't want to operate on a tumor that's already that's really showing treatment effect and that is mostly necrotic. So a lot of work is going to that differential. Then we look to see, are there symptoms, and is there a lot of mass effect? Is there swelling? Is there the next layer of the clinical decision making is what are the benefits and the risks? Do we need more information to inform a clinical trial? Is it the symptom relief? What are the goals? Are we just trying to get that level I showed on that graph, trying to go from 100 billion to 10 billion cells and prolong life that way? There's definitely evidence that surgery helps prolong life. So we have to think about location, location, location. Where is that tumor? What are the risks? If the patient comes out impaired, um, there are always alternatives to surgery. So we discuss that as a group before making the recommendation.
Okay. Um, Somebody asked about leading edge radiosurgery. You know Dr. Christopher Duma? He's out west. They do leading edge radiosurgery where they look at the tracks, they predict where the tumor might theoretically grow, and they treat that with radiosurgery.
No.
No?
Yes, but some of that work has come from Penn. There's a uh, predictive algorithm where and that work was by Christos Davasikos, and Bob Lustig has advanced that as a protocol to NRG, and that's very exciting because it's like Wayne Gretzky said, he goes not where the puck is, but where the puck is going to be.
Right, exactly.
Yeah, so I think that makes a lot of sense, and we have a protocol open at Penn for that.
Good. You mentioned I'm sorry, supratotal resections. Is
Yes.
that something that's becoming more popular now, or is it just experimental?
Well, it's not experimental, but I think it is a trend. It is becoming more accepted wherever. Again, maximal safe resection, um, wherever we can move the margin, because we know what we don't see. We're only seeing the top of the iceberg with glioma. So if we used to be thought of as edema is really infiltrative edema is really invading glioma cells there, and if we can remove those, that makes a lot of sense to be a little more aggressive, as long as it's not in what's called eloquent area. So we'll do stimulation, subcortical tract stimulation. We'll look at the DTI very carefully and try to come up with a reasonable, personalized plan for the patient. I
Okay.
think all of these nuances of surgery are certainly helping the outcomes.
Yeah, somebody asked, they had an acoustic neuroma surgery, and it
Mm-hmm.
took a really, really, really long time. How could the surgery take that long? How could you spend that much time inside a person's head? What takes so long?
That's a great question. Well, when I, and it's really not the time of surgery. It's really how the time of when a patient leaves the hospital and what condition. So that is very delicate surgery, and the price for injuring a blood vessel or injuring the nerve can be a lot of pain and hurt down the road. So surgeons are known to just settle down and take their time. The patients sleep the whole time, and there's no rush. So
Okay.
yeah.
Would it make sense? There's a lot of vaccines out there and the CAR T cell therapies and the vaccine therapies. Would it make sense if it was possible to combine some of these? Or do you think eventually it's going to be one of those by itself might be a cure?
No, I think we're betting on combinations. Um, Combinations work for have controlled HIV. Combinations have controlled many things from tuberculosis to malignant hypertension. I think it's going to be combinations just because of the heterogeneity of the gliomas and uh, also laboratory work where combinations seem to be more powerful. It's just which combination for which patient. And how to design trials that can get me because our population is so diverse.
Okay. Um, you mentioned that all of your clinical trials are closed right now. That's happening across the whole country.
Yes.
Is there any way to maybe get these experimental treatments on expanded access for people who need a treatment right now?
You mean to, yeah. Well, we're all hoping, this has been a very incredible few months.
I
And
know.
yeah, we're, we're all hoping we'll get back to normalcy sooner than later. And it has affected um, how we approach brain tumors and brain tumor clinical trials. We know how important it is, but we don't want to we don't want to put patients premier no serum. So we are doing more quote elective surgery. Cancer, the American College of Surgeons has said that cancer surgery is not elective. It's not elective like other types of surgery.
Right.
And so we're going ahead with that, but we're taking a lot of precautions. Um, I think I can't really say, if it starts to, it depends on the plateau and the mitigation and all that.
Okay. We have this patient. She has a meningioma that's been relatively good for like 4 or 5 years right now. She takes an MRI every 6 months, and it's her time right now. Do you think it's safe to take an MRI right now at an outpatient center, or should she just wait until this is all over, the COVID-19 stuff?
Well, I know, yeah, I don't think there's anything specific about that outpatient center except going out, just like going out to the any population center, right? Going to
I'm sure they sterilize the insides of the tube between patients.
yes, yeah. Uh, some of our patients have requested that they're in lockdown mode and that they delay active surveillance for as long as they're not having any symptoms.
Right.
I think it would be not unreasonable to wait just for peace of mind, right?
Yeah, that's true. Um, okay, now the tough questions.
Those are softball questions.
Those are
No,
the soft ones to get you ready.
yeah.
Now, if you or some of your loved ones were diagnosed with glioblastoma now, what would your treatment plan be from start to finish, basically?
Wow, that's a good one. Well, first, every patient should get standard therapy. So I would get maximal safe resection. I have a surgeon who I trust, and make sure as much of the tumor safely can be removed. Then the Stoop protocol. Then I would have that patient cared for at a center of excellence. I would want to know what are the clinical trials. I certainly will be biased for targeted therapy or immunotherapy,
Hmm.
and I'd probably call you up, Al. I go to I go to clinicaltrials.gov, or I go to place for clinical trials. So um, does that answer it?
Weaseled out of it, but that's okay.
Please, okay.
Um,
Well,
if you have a surgery, what can you do with that sample of brain tissue that's removed so it's not just wasted? Like, would you freeze it until
yeah.
DC Vax was available, or
Yeah, so
send it
we
for genetic?
published a paper in Cell. We have this Translational Center of Excellence. We're developing organoids in that TCE. We're developing PDX, patient-specific models. Um, we're banking it. We're studying it for everything that we can. And so I think, yeah, it should never be wasted.
Okay. Do you think it's worth trying to save to freeze it in case DC Vax gets approved in the next 6 to 12 months? Or that would be a waste.
Yeah, or in other vaccines,
Or
sure.
other vaccines.
Absolutely, yeah,
Okay.
absolutely.
You mentioned the IL-6 inhibitors. Which one did you
Yes.
say you use?
Well, we have a trial developed with Steve Bagley and myself, which combines Actemra with atezolizumab, which is Tecentriq, which is a PDL1 inhibitor, and also involves stereotactic radiosurgery. So we can stimulate and develop some neoantigens using radiation therapy, and that's going before the NRG. So that's not open yet, but that's just around the corner.
Okay, let me see. We're just about out. If anybody has any more questions, start typing them. Oh, okay. Here's an interesting one. Is there a significance to your HLA blood type as far as how vaccines would work on you?
I'm sure there are, but we don't have enough data yet to have specific HLA types, but absolutely.
Okay, and right now, would a checkpoint inhibitor by itself really be useful, uh, or it has to be combined with something?
From preponderance of data, the answer to that is it has to be combined with something.
Let's see. Um, okay, that
Checkpoint inhibitors as monotherapy for gliomas has been disappointing.
yes, I agree. Um, that looks like all the questions. There's one question left. It's from one of your old patients, but I'm thinking maybe after this meeting is over, we could just talk with her privately. It's an interesting
That'd be,
question, but it's
that'd be
private.
great. That'd be great.
Okay, so we're going to end the meeting now. Thank you very much, Dr. Brem.
Thank you for this opportunity.
We have another webinar next week. Next week's topic is going to be advances in neuroimaging. It's a fascinating program. This researcher has a way of telling pseudoprogression from progression and an early way to tell if a treatment is working way before regular MRIs or symptoms would tell you. So it's going to be a good one next week. So everybody should join in next week. I'm going to end this meeting for just about everybody, but I'm going to keep Dr. Brem on and this one patient. So everybody else could leave, and see you next week. Thank you.
So thank you for all the wonderful work you've done, not only today, but all your life. You really are amazing, amazing person. One of my heroes.
Oh, thank you. You're one of my heroes.
Thank you.